Welcome back, everyone. I will be introducing Dr. Ndidi Unaka, our Chief Health Equity Officer for Stanford Medicine Children's Health. Really excited to hear from her today and get the afternoon kicked off. So, Dr. Unaka.
Thank you all for having me. It's a pleasure to be here today. I will talk for just a few minutes, and hopefully we have time for me to take a couple of questions. And so the title of my remarks is Inclusive Practices and Innovation. And I just want to start off talking a little bit about the ways in which technology has advanced the care for children, adolescents, and other patients with chronic medical conditions. And as I was reflecting on this presentation, I thought a lot about our children and adolescents and young adults who have type 1 diabetes. In the US, we know that over 350,000 children and adolescents have diabetes, and of those, over 300,000 children and adolescents have type 1 diabetes. We also know that we have made extreme advances in technology to support this patient population, including advances in insulin pump usage, continuous glucose monitors. We use remote patient monitoring to further facilitate the engagement between patients, families, and their providers. And we leverage the electronic health system in order for families and providers to be able to readily exchange information. We also know, just looking at this timeline, that these advances have occurred over the past 100 years, with insulin pump usage becoming first prototyped in the 1960s, and then the Food and Drug Administration approving continuous glucose monitors back in 2001. And even though this is the case, we also know that we have significant disparities in both CGM usage when we look at racial and ethnic children and adolescents. Same can be said for insulin pump use, and same can be said for their integrated use to control for type 1 diabetes. I'm going to share some quotes that I would just love you all to take the time to review by Dr. Shivani Agarwal and her colleagues from Albert Einstein. They did a qualitative study to really understand what are the underlying root causes of health inequities as it relates to technology usage for our young adults with type 1 diabetes. Their study included over 40 participants. 72% of them were insured by Medicaid, 72% of the participants were Hispanic or Latino, and 28% of the participants identified as Black or African American. And you can see here, there are lots of themes that were elevated in this study. The quotes here really highlight the ways in which this patient population are often not aware that technology for their type 1 diabetes is even available, right? So it begs us to ask ourselves, why aren't we having these conversations with our patients and families who come from marginalized communities about these readily available technologies? They also highlight the ways in which there are expectations for them to be able to access this type of technology, needing to meet what oftentimes, from their perspective, seems like unreasonable thresholds in order to even have access to insulin pumps or continuous glucose monitors, needing to show that they have better control of their type 1 diabetes, even though that seems counterintuitive to the purpose of the technology. We also know from this study that many of the participants highlighted some of the concerns that they had with the technology in and of itself, as well as the influence of shame and stigma associated with type 1 diabetes that likely hindered their desire to want to have continuous glucose monitors or insulin pump usage. And then we also know that technology has been pretty informative in supporting the ways in which we care for our children and adolescents with complex medical problems, children who require various technologies like ventilators and tracheostomies to help them breathe, feeding tubes to help them ensure they're getting adequate nutrition. And this was a study looking at a novel hospital-to-home intervention to support children with medical complexity that was done in Canada. This usability testing study really wanted to assess areas of strength and opportunity within the DigiComp Kids system, which is the hospital-to-home intervention, and wanted to get the perspectives of patients, families, and providers. This tool is really meant to allow families to share various information, whether it be heart rate, respiratory rate, and other important data points with their providers. Their providers can then provide information about care management and medical decision-making that can inform the care of the patients who are at home. And this is something that we know that is really important, especially as we try and broaden access to care in areas where there may be less readily access, depending on families who might live in more rural communities. But the authors highlighted some significant limitations to their approach. They were mostly able to talk to participants who were predominantly female, predominantly white, predominantly university educated, and these participants often had a pretty good baseline comfort with using technology. And so with this limitation, how are we missing the opportunity to design for patients and families that come from marginalized communities that might not have the digital literacy that these families have? And so this is a quote that is often ascribed to Picasso, where he says, there is only one way to look at things until someone shows you how to look at them with different eyes. And I think this quote really resonates with me, right? We often think about not just design, but most of what we do based on the individuals with whom we engage with. And I'm really pushing that we engage with a broader audience, that we engage with broader partners and stakeholders in order to inform what we do within healthcare. And so there's this idea of responsible innovation, which is the need to think carefully about potential impacts of technology, the need to work proactively to identify and adapt that technology, and the need to work with end users to ensure the best outcomes. When we think about responsible innovation, there are 4 key principles: anticipation, reflexivity, responsiveness, and inclusion. When we think about anticipation, it's really all about anticipating what could potentially go wrong in the design and implementation of a particular innovation or technology. When we think about inclusion, it's about who's at the table to help us think about, the ways in which this technology could be useful. And how do we ensure we create space for everyone to be able to share their opinions in a way that really dismantles the power hierarchies that could keep people from sharing openly? When we think about responsiveness, what are the ways in which we elicit the concerns of the end user and use that to inform our design and implementation strategies? And reflexivity is all about the ways in which we reflect on our own social identities and how that influences what we design, and the limitation of our own experiences and wanting to broaden that experience and ask questions about who's not at the table to inform this particular innovation or technology. And so why inclusiveness matters for innovation? We know that engaging with end users early is really important in the innovation process. It allows us to really augment the range and depth of solutions by thinking about who needs to be involved, and by creating space for that, we're able to design an even better product for our patients and families. And then it helps us think about compatibility within the context for which our patients and families live. They know best about what's going to work within their contexts or environments and what's not going to work. And finally, I loved this quote because I think it pushes us to think beyond ourselves. We often design technology from the perspective of the physician or the other members of our healthcare team, and we're doing it on behalf of our patients and families. But what ends up happening is that we create a space where we are consulted about particular technologies, and our patients and families are disenfranchised, particularly our patients and families who come from marginalized social identities. And so we have to think about really pushing against this notion that the doctor knows best and creating spaces for our patients and families to be at the table, because that's why we're all doing this in the first place. So with that, I am happy to answer any questions that you all might have, and thank you for giving me the opportunity to just to share a few remarks.
I was thinking about this anticipation. Maybe I should introduce myself. I'm Toby Lund from University of Technology in Chalmers, Gothenburg, and I'm working with biodesign here. So anticipation, when you find something that might be of dual use, that might be potentially dangerous, what should you do then? I mean, almost all good technologies will have that.
Yeah, no, I think that's a fair question, and you're right. You know, there's benefits and disadvantages to everything. I think it depends on, what is the scale of that, disadvantage, right? Does it mean that we shouldn't try and implement and learn how we adapt? But we won't be able to know those things if we don't ask the right audience, right? I think sometimes we design and we create various innovations without asking the right people, and then we find out about those disadvantages or dangers late in the game. So I think it totally depends, but I think trying to identify those things early allows us to figure out how we adapt for them.
Dr. Anaka, do you think that hospitals have any kind of a social responsibility when it comes to helping underserved patients have access to technologies, maybe even like as simple as the Wi-Fi, to use those technologies to do those telehealth visits? It's like there's a divide that needs to be bridged, even that goes with the education of the patients that you were talking about.
Yeah, absolutely. I think that's such an important question, and I think healthcare systems, in conjunction with other sectors, should be putting their heads together and figure out how we address the digital divide. I think this was something that really came to a head in COVID, when our healthcare systems had to quickly transition from providing care majority in person to leveraging telehealth. And then we came to realize there are so many communities that don't have access to reliable internet, or may not have access to the technology that allows us to deliver that type of care. And so I don't think it's the responsibility of the healthcare system in and of itself, but I do think we have to be a part of the equation. I think I often reflect on this too as we design technologies, and I get why we do this approach. We often design first for what is easy, right? Because it's easy to design, for example, our English-speaking patients and families, and then think about what are the ways in which we can design technologies for our families that speak a primary language other than English. But I think what ends up happening is that, we further widen the gap of inequity, by trying to think about who we should design for first. And I know it's not always possible to try and design for all of our patients and families, but I would push us to try and think about that earlier on. It takes more time, but I think it is critical to our efforts to really try and advance health equity.
Forgive me, I missed a couple minutes, and maybe you already answered this, but in case you didn't, I'm really curious to hear how you feel it's going. We've been talking about inequity in design and distribution of different kinds of treatments and diagnostics for some decades now. I'm curious to know how it's going and what we could do to accelerate.
Yeah, I think we have a lot of work to do. And so, at the beginning of my talk, I talked about I used our type 1 diabetes patients as an example in the ways in which we've really advanced care by leveraging technology, and yet we still know that equitable use and equitable deployment of technology remains an issue. I do think a lot of the root causes that lead to inequities in leveraging technology are the same root causes that lead to inequities in other forms of health delivery. And so I think in general, we know what is at play. I think coming up with solutions to address them is easier said than done. But I think we have to start thinking about that in this space to really make an impact. And I think there are some places that have really started to do that.
Hi. Innovation is only as good as the adoption, and equitable adoption is huge, as you have rightly pointed. What are your thoughts on providing optionality to the patient population when, if a healthcare system is, let's say, in remote patient monitoring with some of these, providing that optionality to the patients? It does make your adoption and execution more complex, as well as reimbursement more complex, but I think it's so important. I would love to hear your thoughts on that.
Yeah, can you provide a little bit more specificity? So when you say provide optionality, what do you mean?
So let's say it's a rural patient versus a community center patient. One patient may want to use telehealth, the other patient doesn't and would prefer to come into the clinic. But a one size fits all in terms of the adoption by the hospital system may not work.
Yeah, no, I think that's a great strategy. I don't think it can be a one size fits all. I think that's often easier for us, and it's not to say that designing in a way that allows some flexibility to meet the needs of our patients and families is not, I don't mean to make it sound like it's not easy, but I think it's an important way of addressing the gap we have. I think remote patient monitoring is really interesting. We use remote patient monitoring for a lot of things, type 1 diabetes. At my prior institution, we used it to provide support for families of infants with poor weight gain. We were using it for asthma patients. And we were getting feedback from families, particularly our asthma patients, who felt like it was almost like Big Brother watching them. And so it allowed us to then adapt our remote patient monitoring to increase the adoption as you highlighted. So I think that's such a great question.
Okay, we'll take this one last question.
Thank you for your talk. I just wanted to know if you could comment on the issues of equity and innovation for children with physical and intellectual disabilities. In particular, why have we been so late to the table in attacking ableism?
Yeah, this is a topic near and dear to my heart, and the paper I cited was specifically about hospital-to-home interventions for that particular patient population. It's interesting when we think about patients who have significant neurologic impairment or significant needs for technology. I think that patient population has been left behind. I can't hypothesize with great certainty as to why that's the case. Reimbursements may be the case, though, because many of those patients are insured by Medicaid, or for an older population, they may be publicly insured, and so I wonder if that has something to do with it. But I think it's a patient population that we don't necessarily appreciate the burden their families have on providing care. When those patients have 4 clinic visits and we don't think about ways in which we consolidate those visits to one day. We don't think about offering telehealth as an option if it really doesn't require an in-person visit. We don't think about the ways in which these families rely on home health nurses and other entities to provide support. So I think there's just a lot of work that we can do in that space, and I appreciate you asking the question.
Thank you so much, Dr. Naka. That's
Yes.
wonderful.
Thank you.